I'm going to share, some of the outcomes that you mentioned. I'm going to share some of the actual results, and maybe you can speak to how that has potentially changed practice, either at your institution or even across the UK. So you mentioned symptomatic rhythm detection in the population receiving the Kardia mobile device versus the control population. And it was fivefold increase in detection using Kardia. So 69 individuals were a rhythm was captured versus 11. When we look at an arrhythmia, so an actual abnormality that was detected, it was 11 versus 1. So 11 folks on the Kardia side, an actual, whether it was AFib or a flutter, SVT. The time to detection in the Kardia group, 9.5 days versus 42.9 days in the usual care group. And then that arrhythmia, the abnormality, similarly 9.9 days versus 48 days. So obviously more rhythms are detected much sooner than usual care. All great things. And then from a cost perspective, as you mentioned, the cost per diagnosis was also significantly less than usual care. So all these sound great. How has that changed practice, for you or for other organizations?
Yeah, definitely. I mean, first of all, as well, it also demonstrated the characteristics of the patients that come to us with palpitations. So we detected about 15% altogether had a cardiac cause, and the other 85% all had benign causes. So
Mm.
that I think, as far as I was aware, was the first time we'd actually uh, captured the underlying arrhythmias causing palpitations in an undifferentiated group of patients coming to the emergency department. So that now shapes our thinking when you go to see patients, that the majority you'll see have benign causes, and a lot of them we can reassure them because there's some factors in the way they present that we can be confident it's not a cardiac cause. So that was obviously another important thing that came out of it. But overwhelmingly, obviously, we showed that the intervention made a massive difference in picking up, far greater than we expected, actually, it has to be said. Um, Importantly as well, when thinking about how we're then going to embed this into practice, was that although we had 90 days as our outcome, we picked up the majority, more than 90% of these arrhythmias were picked up within the first 30 days.
Mhm.
So that was important in terms of thinking of device turnover. How often we see patients back? Do we need to leave them for 90 days before we see them again? Because the disadvantage is that the patient may sit having had their cardiac
Mhm.
arrhythmia, and they're not going to be seen for another 3 months.
Right.
Whereas we can see them back a little bit earlier if there's a very good chance. So, more than 9 out of 10, we had an underlying diagnosis within 30 days. So that was another important thing that came out of the study. So obviously, with those tremendously positive results, um, what we decided to do was then integrate the iPad findings into our practice within the emergency department in Edinburgh. So
Mm.
we set up something called the Smartphone Ambulatory Palpitation Clinic several months later, and we ran this through our ambulatory care team. Um, and it's similar to an SDEC, same day emergency care, which is a concept that's very common in England and Scotland.
Mm.
Um, and the reason for that was because um, it, it took a few minutes for the patient to be able to download the app onto their phone, to talk them through how to use the device, to set them up on it. And our emergency department is tremendously busy. We have
Mhm.
lots of clinicians working in it. We can't expect to train them all up in how to do this. We wanted to provide a really good level of care so that patients were really comfortable in what they were going to be doing. So that's why it was better suited to a clinic setup. But we were able to bring people back the next day. So once we see them, they've got palpitations that we're concerned might be cardiac. We refer them to the next day ambulatory clinic where they
Mm.
get seen by our acute medicine team. Their history is revised, gone over again, and about 90-95% of them are suitable for the device. They clearly have a possible cardiac arrhythmia, and they're set up within the clinic there, and sent off with a device. And we set that up 5 years ago now, and have been running the service since then.
Wow. Wow. Um, and then that's tremendous, to take, clearly, from the outcomes of the study to actual clinical care and clinical practice, which doesn't always happen at the speed of which you describe. And then also, if you look at kind of nationally, broadly, how do clinical practice guidelines change? um, I'd love to kind of touch on a little bit of that, and how, when we look at NICE, the National Institute for Health and Care Excellence, across the NHS, which publishes guidelines for clinicians, to use. They have recommended Kardia Mobile for detecting atrial fibrillation in specific populations. How does research like this, whether it's the iPad study or other studies you've done, influence NICE and their recommendations, so it is a more broad recommendation?
Yeah, so as you said, so the iPad study was looked at by NICE, who regularly review research that's been published in certain areas, and when new research becomes available, they then embed that, if it's positive research, into their guidelines. Um, so they published a guideline on the use of KardioMobile for detecting atrial fibrillation, and um, the iPad study provided really strong real-world evidence that shaped that decision in populations who we have undifferentiated palpitations, and uh, it highlighted the limitations of traditional ECG monitoring, such as 24-hour tapes, and it demonstrated that um, the smartphone-based ECG event recorder technology could improve early atrial fibrillation diagnosis. It was convenient for patients. There were NHS cost savings, and they recognised that it's a viable alternative. And obviously, our study showed far better than standard care for suspected AF. So um, the research such as this is absolutely fundamental in shaping NICE recommendations to ensure that the guidelines that are published are based on the best available evidence. Um, and they look at all, so they do systematic evidence reviews. Um, I was asked to provide a bit of background about the study. They asked me to provide a bit more data that we hadn't published, some raw data as well, and they look at health economic modeling as well. So look at other studies that they can pull the results with as well, to look at the health economics as well. And yeah, so they do that process all the time as new evidence is becoming available.
Well, thank you to you and your team for helping advance and for that recommendation from NICE. We've certainly heard from others across the NHS who referenced that guideline in evaluating and implementing solutions like this. Since that recommendation, or even since the publication of the study, and I know now it's 5 years on, and your center has been able to implement this clinic. Have you heard from other of your colleagues across other institutions, or emergency departments, who've done similar things using the device?
And we certainly have a lot of interest in how we've set up the clinic, and we make our SOPs available to anyone else who wants them. There are yeah, loads of hospitals who are interested in how we do it and how we set it up, and I am aware of some other hospitals who also have a similar type of service available. Um, and I mean, and well, yeah, with our own hospital, we looked after a year. We had about 240, 250 people through the clinic, and we're just looking at our 5-year data now. So we've got more than 1,500 patients now who have come
Wow.
through the service over the 5 years. So we're looking at some of that data to see whether there's things we need to revise about. Are we still providing the best service? Are there other ways that we could do it?
Yeah. Wow. To that last point, are there other ideas or other if you could do the iPad differently, if there are things that you wish you would have measured, anything else that you would have done differently?
So I suppose there's two things. There's one, what we could have done differently about the iPad study, and I think probably going back, I think um, within the study itself, the device was placed by research nurses
Mm,
who is very common for research projects and research studies in the UK. It's delivered by research nurses, which are supposed to get away from the clinicians. So clinicians identified patients, and then the research team in all of the centres then randomised the patients, did all the research side of things, but and then fitted the devices. Um, it would be I think have been a good idea to actually deliver the study in the setting that we were probably going to then deliver it in. So, for example, we would have delivered a service. The implementation part of it would be that you would, if the patient was randomized to device, rather than fitting it in the emergency department with our research team, we would have brought them back the next day to the ambulatory care service
mhm.
and looked at the sort of embedded it in clinical practice um, and looked at the results in that setting as well, which is what we're doing now.
Right.
Um, but that probably would have allowed it to, in certainly the 10 sites, to run much more easily into standard practice.
Mhm.
Whereas the sites that took part in it had research nurse infrastructure and then had to go about setting up a ambulatory care separate service to be able to run it like we did. And it
Yeah.
might have been able to run much more easily into the service. The disadvantage of that, obviously, is the fact that um, there's so many different ways you can run a service like this. So it
Mhm.
doesn't have to be delivered the way we're delivering it. Um, and the way we did it means that each site can then take the findings and then put them into practice in whatever way would suit their site the best.
Mhm.
Um, so, for example, there's lots of things that have happened since we first started it. Kardia have got a dashboard now where patients can record the ECG and clinicians can get immediate access to that. So rather than the patients having come back to the clinic and we interrogate the phone where we did initially to look at the recordings they'd made, um, we can have a dashboard whereby that tracing is immediately sent to the clinic and someone can have a look at that every morning and look at any rhythms that have been picked up, pick up the phone to the patients and can get them back or even just have that consultation over the phone.
Mhm.
The reason we brought back people initially was to be able to improve our turnover of devices as well. Again, another cost-effective strategy that we bring the patient back. You can have a face-to-face consultation with them. That's
Mhm.
probably better to relieve their anxiety, to have a proper conversation about what the underlying cause was, and it enabled us to get the device back. And the problem was they were so popular that there were a lot that sort of went missing, and I suspect it was the fact that patients liked them so much they were after having their own rhythms diagnosed, were then handing them around to their friends or
Yeah.
so they could also do the same. Um,
Yeah. Or
and
they wanted to be sure the next time they had symptoms, it was the same benign trace
absolutely,
maybe. Yeah.
absolutely.
Yeah.
So we did have a turnover of devices. We lose about 20 to 30% a year, which we have to top up. Um,
Yeah.
but at the moment, we are still bringing patients back. But there's obviously lots of models where we can move to different ways of delivering the service.
Yeah. I guess to that point, I imagine you can see this same implementation happening in a GP's office or a specialist office where instead of that patient coming to the emergency room for those symptoms, they might be going to their GP, and the GP can do the same thing that you guys did. Is that fair to
Yeah,
say?
absolutely. I mean, patients do present to us quite a lot, but patients do present to their GPs. Um, People may present to pharmacies, and I know that pharmacies are now using a live core for picking up asymptomatic atrial fibrillation, so for screening for atrial fibrillation. So pharmacies are quite used to it. Um, I think there's still a lot of learning about palpitations. I think GPs and pharmacists would still be quite concerned seeing someone who's got ongoing palpitations. The AliveCod device can obviously make the diagnosis whether it's an SVT or likely atrial fibrillation, or confirmed atrial fibrillation. But then what do you do with that? Uh,
Hmm.
so where does the pharmacist send the person then? They're still having palpitations. They're likely to send them to the emergency department. And I think probably it's something that GPs are not commonly seeing.
Hmm.
So in the same way that I'm probably not happy knowing what the latest anti or the hypertensive guidelines
Right.
are for people with chronic hypertension. I have to go and look them up. It
Yeah.
it's probably the same for GPs with acute palpitations, that they'll
Mhm.
know how to manage AF, but they might not know what to do with someone who's actively having SVT or atrial fibrillation. So there's so many ways that we could incorporate this into GP practice and pharmacy. It obviously have to come along with a little bit of learning. But the beauty of this is that the things we're finding are, as long as you don't have a fast atrial fibrillation, or you've got ongoing SVT, which you're symptomatic with, which we obviously need to see in the emergency department. If it's a short-lived episode that we've picked up, you're now symptom free, you're back to sinus rhythm. Um, GPs can more than adequately manage SVT,
Mhm.
with referral to cardiology in a less urgent setting, and obviously are very capable of managing atrial fibrillation with
Yeah.
um, risk stratification for anticoagulation and starting on rate or rhythm control.
Yeah. Well, obviously, this study, if you go back to kind of how this all started, it started from a consumer idea, a consumer concept, a device that your friends were using, or an idea that they were using, and then you turned it into something very clinical, and with very profound impacts on patient care. How has that influenced sort of your um, perspective on digital health and tools that may not be standard of care in traditional clinical settings today, but could be tomorrow. Obviously you're someone who's willing to take those risks and try these technologies, but how has that influenced kind of future research for you?
Yeah, absolutely. So I think what this study shows is, although it took 7 years from the idea initially to getting the grant funding, setting up the study, doing the study, then implementing it clinically, um, it was, I hope, a well thought out, well designed study, and it showed um, that the benefits of doing that type of study is really able to change patient care and to change guidelines. And sometimes these studies do require a reasonable amount of funding. I said this was delivered very relatively cheaply for a randomized controlled trial. Sorry, a randomized controlled trial. Around about £50,000 was our budget for this, which is
Hmm.
amazing for a
Wow. Wow.
multi-center randomized controlled trial. But
Yeah.
um, studies that are well designed, that are well funded, that um, have a very clear clinical problem. So starting with a clinical problem that we need to solve, um, that has the right study design, and that is not always a randomized controlled trial. They give higher quality evidence, but a pragmatic study in a real world setting, which ours was, but a really well designed one, doesn't have to be a randomized trial, can also be very helpful. It's important to engage clinicians and patients, especially really early. So the study mirrors clinical reality. We recruited patients in our emergency department who were there at the time with their episode of palpitations. Um, we need to make sure that we collect the right data. Um, we sometimes can collect too much data. We need
Mhm.
to make sure we're collecting the right clinically relevant endpoints that are then going to change outcome. We need to collect both clinical and economic data as well. So quality of life information, cost per diagnosis, and impact on hospital visits and things like that, and standard care costs, so we can assess the economic evaluation. We need to plan early on for implementing it into the real world early on. Who's going to use technology? What training will be required? How is it going to fit into NHS pathways? If data is involved, how will the data integrate with NHS systems? Um, and if we think of all those things, we're more likely to get it published in high impact journals, and that more likely to get picked up by NICE and the Scottish Health Technology groups, and other organisations and policymakers that are involved in then setting the standards and defining the guidelines, writing the guidelines for patients with these conditions.
Yeah, yeah. Well, thank you for that a really clear kind of blueprint, if you will, on how to do studies like this well. I think it also needs a forward thinker like yourself, someone who's willing to embrace technologies and novel solutions to do studies that like this and others. So again, thank you for being the champion for looking at a consumer technology and bringing that into clinical care to really change and drive better outcomes for patients. Well, I know we're at time. You've been very gracious with your time, and I've learned a ton from you in this short hour. I really want to thank you again for not only doing the study, but for being a real advocate in advancing emergency medicine, both in the UK and worldwide. We in the US and others look to studies that you've done and others in your space to really change practice and drive the right outcome. So thank you again, and again thank you, Matt. Any last words from you?
No, at all. It's just I love talking about research. I love talking about some of the things we do, and yeah, it's really good. Thanks for having me on and the opportunity to be able to talk a bit about the study and talk about the journey from the concept into now obviously embedding it into our care and hopefully a lot of patients who have benefited from getting their cardiac arrhythmia picked up and treated earlier than they would do otherwise.
Absolutely, and they absolutely have, and thank you for that. All right, well, have a great day, and hope to see you soon.
Great to talk to you, Ben. Thanks.
All right, thanks, Matt.